Good morning, all. So I'll be talking on a clinical-based discussion on the side effects of glaucoma medication. So this is the classification of the drugs. The adverse reactions can be from the main agent or the preservatives. Drug allergy is the most common important side effect. Brimonidine commonly causes drug allergies and can be delayed for many years. The topical complications are more frequent with prostaglandins, and systemic ones are more frequent with beta blockers. Brimonidine is no benign offender. Beta blockers, owing to their affordability and efficacy, they are frequently selected as the initial therapy, either as monotherapy or in combination regimens. So this is the story of a patient who first time was diagnosed glaucoma. He was a famous writer. When I asked the history of bronchial asthma, he denied. But a week later, he brought me the leaflet from the eye drops and told me that it is written in this, you will get bronchial asthma if you use this drug. So some patients, even if they don't have the history, 1 in 50 of the patients can develop an obstructive airway disease, even though they don't have the history of bronchial asthma. Bronchial asthma, there are so many patients who were using beta blockers. When you stop the drug, you can see the improvement in their obstructive airway disease. So when you ask the history of bronchial asthma, you can ask whether they're using a steroid inhaler, because steroids are notorious to produce the exacerbation of the increase in IUP, steroid-induced glaucoma. So even though the inhalers have only topical effect in the bronchial muscles, they still can produce, several studies show that they can also produce raised IUP in especially in advanced cases. You can refer the patient to the pulmonologist for an alternate therapy in advanced glaucoma. This is the story of a cardiac complication that has occurred to an ENT surgeon's wife. She was admitted with recurrent attacks of syncope and was diagnosed as arrhythmia, so necessitating the discontinuation of beta blockers. So you have to assess the pulse before prescribing, and in cases of Raynaud's phenomenon also, you have to discontinue beta blockers. Then this was a story of a patient who came for diabetic retinopathy evaluation and was diagnosed glaucoma. She was referred to the physician for diabetic control. He gave history of recurrent attacks of folds. So when I talked, she said she doesn't have any history of tremor or sweating. And when I stopped the beta blockers and she came later, she didn't give any history of hypoglycemia, maybe because the physician has titrated the drug. Then nocturnal hypertension in patients with compromised disc perfusion can also cause constricted fields. So in such cases with advanced glaucoma, if the patient is taking antihypertensives at night, you have to refer the patient to evaluate for nocturnal hypertension and make changes in the drug. It can cause CNS depression, aggression of myasthenia. There can be topical side effects like conjunctival congestion and foreign body sensation. Because of the membrane stabilizing effect, it can cause local anesthesia and reduce reflex tearing and epithelial toxicity. And about the alpha-adrenergic agonists, brimonidine is the commonest one which we use. It can cause allergy ranging from varied grades, including simple itching, hyperemia, severe congestion, and contact dermatitis. This is the story of a woman who came with a history of glaucoma for 2 years. She was on 3 drugs and she was having recurrent attacks of redness, and she was treated with steroids, all sorts of steroids, loteprednol, prednisolone, and systemic steroids. But her IUP was not controlled and she was getting recurrent attacks of redness. So in view of the corkscrew vessels, she was advised a digital subtraction angiography by an ophthalmologist. When I took the history, I came to know that her redness was subsiding when she took steroids. And she never gave a history of itching. So when I stopped brimonidine, a week later, she came with a white eye, and her IOP got controlled in 2-3 weeks' time. So then contact dermatitis is also very common with brimonidine. The picture below is that of a patient who has a hyperpigmentation, thickening of the lids, and when you discontinue that disappears. The picture above is a patient who was on treatment from a dermatologist for his skin condition. That was a steroid ointment. He was also having a contact dermatitis because of brimonidine. When we stopped the drug, the skin condition improved and we could withdraw the steroids, and IOP also got controlled. So when you may get certain cases of follicular conjunctivitis as a complication of brimonidine, so these allergens should be stopped to prevent conjunctival inflammation, because at some cases you may have to take the patient for trabeculectomy. We need a good loose supple conjunctiva for a good blood formation. So there can be other systemic side effects like tiredness and dryness of mouth. These are not very rare, and it is contraindicated in infants and children due to the CNS depression, respiratory arrest, seizures. The risk of hypertensive crisis when given with MAO inhibitors when the patient take that for depression. Then it can cause granulomatous anterior uveitis, and you can prevent the absorption of the drug by closing the lids for 3 minutes. That reduces the absorption by 50%, and lacrimal occlusion enhances it. Epithelial drug toxicity can occur with any of the anti-glaucoma drug, and especially when topical drops with benzalkonium colloid preservative. It is more common with dorzolamide. You can use drugs with preservative-free drugs, or the ones with which are more cornea-friendly preservatives, and can use lubricants, frequent lubricant application. And you can take the patient for surgery if none of the drugs are tolerated. Prostaglandin analogs are notorious to produce hyperemia, bimatoprost more than latanoprost, and then comes the travoprost. Iris hyperpigmentation, blurred vision, skin hyperpigmentation, orbitopathy, exacerbation of keratitis, cystoid macular edema, and hypertrichosis. You can see the picture of a hypertrichosis, and the patient below is having hyperpigmentation as well as hypertrichosis. So when you discontinue the drug, the hyperpigmentation, all this can disappear except the iris hyperpigmentation. So this hyperpigmentation actually happens in the epidermis level. So this epidermis is frequently shed. So renewal happens and you can get lighter colored skin. So this is a case of prostaglandin associated periorbitopathy where there is upper lid ptosis, deepening of upper eyelid sulcus, periorbital fat atrophy, and mild inophthalmos. You can see the video of the tight lids. When I try to pull, the lids are not, it's difficult to pull the lids, and the eversion is also difficult. Then the systemic side effects can induce uterine contraction and premature labor. The systemic side effects are few with prostaglandins, can sometimes cause flu-like symptoms. It is contraindicated in pregnancy, uveitic glaucoma, immediate postoperative period, and healed or active herpes simplex. Carbonic anhydrase inhibitors, acetosalamide is the one which we use systemically, and it can rarely cause Stevens-Johnson syndrome. This is a case of Stevens-Johnson syndrome. You can see the conjunctival, a change of conjunctival architecture, and loss of meibomian glands were also for this patient. Electrolyte imbalances is commonly hypokalemia. It can cause metabolic acidosis, paresthesia, urolithiasis, blood dyscrasias, fatigue, malaise, sickling, and sickle cell crisis in those with sickle cell anemia. It can cause choroidal effusion and angle closure glaucoma also. Contraindicated in respiratory acidosis, renal disease, kidney stones, pregnancy, and liver disease. It should be used in caution with corneal endothelial disease, as corneal endothelium also has carbonic anhydrase. And its role is, the risk of reaction with acetosalamide in a patient with sulfonamide allergy is low, and many studies show that it is not. There is no such risk now. However, acetosalamide is listed as possibly cross-reacting with sulfonamide drug in the drug information and the package insert. The parasymptomimetic drugs which we use commonly is pilocarpine, and this is the story of a gynecologist who called me one day telling that I'm having vitreous floaters. I told her to come for a dilated indirect ophthalmoscopy next day. So when I came to the OP, she had already got her eyes dilated. So when I examined, the anterior chamber was shallow and there was a closed angle. Her IOP was 28 and she was in a hurry, so I gave Diamox and pilocarpine and Timolol. And she said, I'll come in the evening, and she didn't turn up. At night, she called me and told that I'm having severe headache. I didn't know whether it was due to an angle closure or a brow ache. She was telling that it was more of a brow ache. So I told her, you take 2 tablets of Diamox and pilocarpine. But next day morning, she came with a white eye, and she said, I took only mefenamic acid. And probably that could be a ciliary spasm. The other side effects include induced myopia, posterior synecdoche, miosis, constricted fields, cataract, retinal tear, retinal detachment, paradoxical glaucoma due to anterior shift of iris lens diaphragm, iris cysts. And it should be avoided in uveitic glaucoma. And rare systemic side effects include sweating, increased salivation, and lacrimation. So rho kinase inhibitors, the commonly used ones are ripasudil and netasudil. Both can cause hyperemia and subconjunctival hemorrhages. And netasudil is notorious to produce vortex keratopathy and ripasudil blepharitis. Hyperosmotic agents, the one which we commonly use is mannitol. It can cause congestive cardiac failure due to increased blood volume, urinary retention, electrolyte disturbances, and myocardial infarction. In pregnancy and lactating mothers, this is a chart which show the FDA drug risk categories in pregnancy. All the anti-glaucoma medications are category C except brimonidine and dipivefrin, which are category B. So, and it should be brimonidine category B should be avoided in nursing mothers but can be used in pregnancy. Beta blockers concentrate 5-fold in breast milk, so should be avoided in breastfeeding children. Prostaglandins can cause uterine contraction and premature labor. In pediatric glaucoma, the drugs available are beta blockers, carbonic anhydrase inhibitors, and alpha-2 agonists and prostaglandin analogues. Alpha-2 agonists have severe adverse side effects in children and contraindicate for those younger than 2 years. Latanoprost is less effective in lowering IOP in children than in adults. So in conclusion, these adverse effects can be minimized when they are detected early, prevented by reducing the number of different eye drops used via fixed combination eye drops, reducing the number of times the eye drops are administered, using benzalkonium chloride-free eye drops, using lower concentration of eye drops, and providing proper drop installation training, educate about adverse effects. Thank you.